that is specific for the heart being weaker. When the heart is weaker, the blood test is high. When the heart is doing fine, the blood test is normal, high and large. And these are a couple of them. One is an old-fashioned one that we used to do called norepinephrine. Norepinephrine is the stress hormone in all of our bodies. So if you're driving into work and you have a car accident, your norepinephrine level goes up, right? Makes you get ready for that fight or flight response. Your heart rate goes up, you might sweat a little more, and then you realize nobody's hurt, and the insurance will take care of it, and you calm down and your norepinephrine level goes down. Heart failure patients, because their body is always under stress because their heart's not pumping enough blood, their norepinephrine levels go up and stay up for long periods of time. And that's actually part of the process of causing advancement of the heart failure. So that's one. We don't use that much anymore to measure it. We used to have people in a dark room lying flat for 20 minutes. Doctors don't have that much time with patients anymore. So there's a couple new ones, but one that you'll hear about is BNP, or brain natriuretic peptide. It's a remarkable biomarker. It's extremely specific for the heart, and it's being measured in doctors' offices, in hospitals, and for lots of reasons. This slide shows how useful it is. When I say one of the symptoms of heart failure is being short of breath, you might say, well, my uncle has emphysema, he's short of breath. And you're exactly right. Someone coming into the emergency department with shortness of breath could have a clot in their lung, could have pneumonia, could have emphysema, or could have heart failure. And you can see that the levels of this BNP hormone are much higher in the patients who have heart failure than who have other non-heart failure causes of their shortness of breath. This is just one more slide showing that actually the level that the patient's BNP level at the moment they get admitted to the hospital predicts what's going to happen to them for the next 180 days. So when they come in and their level is mildly elevated, their outcome is relatively good. When it's high, their risk of death and hospitalization could be as high as 40% in the next 6 months. So it's a powerful marker, and we use it and try to use that to figure out where is that person at and where are they going? How do we look into the future? Let me skip that. All right. How is heart failure diagnosed? Well, first and foremost, it's always a good and careful history and physical exam. The history focuses on lots of things. It could include a family history. It could include really the patient's best understanding of the circumstances where when the heart failure developed. Try to push them back as far as possible because lots of times people deny when their symptoms began. A real careful estimation of what they can do. It helps, particularly in older men that have a spouse there. Because men don't always tell you the truth about when their symptoms began. But it does help to have some validation of that. There are some tests that we do fairly routinely, although nothing is routine these days, and that's an X-ray, some blood tests, an EKG, an echocardiogram, and I'll talk about all of those. This is just a reminder about the sleep apnea. When we're taking that history, we always talk about sleep apnea, and that's why we also have to have a spouse there. Because if you say to the patient, "Do you snore?" they always say, "No, I don't." Well, they're asleep, and they don't know when they snore. It's always delightful to watch the expressions. The men are always, "No, I don't snore," and the wife's going, she's rolling her eyes. Variety of tests we do, and there's a purpose for all of them. We do a blood count, mainly because a lot of people have anemia, and that can actually be one of the causes of heart failure. The heart has to become harder and harder and harder if there's not enough blood flow. That's great because that's a totally treatable and reversible form of heart failure. We check things like sodium and shape. We look at blood sugar, and you can look at that A1C. We look at thyroid. Thyroid, if it's working excessively or not working effectively, both of those can cause forms of heart failure. And just a variety of other blood tests that we might do. The EKG is exceedingly important simply because there are certain heart rhythms that actually precipitate heart failure. So there's a form of heart failure called CAT-mediated cardiomyopathy. That just means that your heart is going very fast. It might be driven by excess thyroid, it might be too much caffeine, it might be a conduction or electrical situation in your heart. By beating faster and faster and faster, the heart can get progressively weaker. That's also great to find out about because by slowing the heart rate and controlling it, most of the time those forms of cardiomyopathy are reversible. And people get miraculously better, the heart function returns to normal. This EKG shows a lot of abnormalities, including a longer time for the heart muscle to beat, and we now have ways of treating that with a form of a pacemaker. A chest X-ray is really helpful, sometimes in determining why they're short of breath. We might see a lung mass, we might see pneumonia, we might see evidence of emphysema. We can also, it's sort of like the rings on a tree, you can tell how long it's been going on. And so you see an X-ray like this, and the patient goes, oh, I feel okay, nothing's really going on. And this is evidence that this patient has had a chronic decompensated form of heart failure for some time. The echocardiogram, many of you probably had one, you've heard about those. This is a non-invasive test that allows us to do many things. We can look at the size and the function of the heart, if it's beating well or not, if it's enlarged or not. We can look at the valves and see if they're functioning okay. We can actually, in some cases, see the arteries of the heart and see if there's calcium in them or there's some blockages. We can see if one portion of the heart is not moving as well as another portion, which suggests that they have blockage in that area. So the echocardiogram is exceedingly important. Sometimes it's combined with exercise and gives us even more information. That is the staging system again. I'm going to let you study that this weekend. So let's talk just very quickly now about what are the goals of treating someone. You figured out that they do have heart failure. You figured out the cause. You figured out what their ejection fraction is. You figured out what their prognosis is. And now you're ready to treat them. The goals are always the same. It's to relieve their symptoms, make them feel better. The second is to improve the quality of their life. And the third, not necessarily in this order, but improve the duration of their life, so increase their survival. And I'm going to skip that one too, but we always start with non-pharmacologic therapy. So we try to use things that are simple, that are effective, but obviously, as the evidence has suggested, everyone who has symptoms will require drug therapy, but we shouldn't miss the inexpensive, non-pharmacologic things to do. What are those things? Exercise is really important. Back when I started training, people were told, you have heart failure, don't do too much, retire from your work, don't exercise at all. That is not true at all. And in fact, the evidence is that exercise promotes good heart function and can make people feel better and can reduce the number of hospitalizations. So that's really the key for exercise. Weight loss in general is advisable because that simply reduces the amount of work that the heart has to do. There are some patients who get very advanced heart failure that get protected. Their muscles are wasting. There's a lot of activity in certain hormones that suppress their appetite. Those patients we don't want to lose more weight because they're just losing muscle mass. But by and large, for most patients, particularly if they are overweight, to lose weight. The next two have received a lot of debate. You've read probably all the articles about salt and so forth. But by and large, people who have heart failure, their hormones are holding on to salt and water. And so we ask them to restrict the amount of salt that they take in. The recommendation here is under 2 grams. The average American probably takes in around 6 or 7 grams of sodium. Also this weekend, when you're really bored, count up how much salt you take in just on your meals over the weekend. The average teenager will take in 10 to 12 grams. If you go and get a Big Mac, for example, that's about 2,500 milligrams in one shot. If you add fries, that's probably about another 2,000. You're at 4,000 after fast food restaurant. Because they retain salt, they then retain water, and so we ask them to reduce the amount of water that they take in as well. We try to get them to avoid drugs that can block the heart failure meds or worsen their heart condition. One of the common ones is the non-steroidals, the ibuprofen and things like that. This slide, you're not able to see very well, but it's in your handout. And this is really a good summary of the therapy. And the point being is that at stage A, when the patient is at risk, the only things that are recommended are reduced risk factor reduction. So if they're drinking, don't drink. If they're using cocaine, don't use cocaine. A lot of education. And if they have things like high blood pressure and diabetes, keep those. So prevent the disease from happening. Once they have stage B, then we add some medicines to it. We think will slow the progression to the next stage. And these are medicines that are commonly used in treating high blood pressure, for example. Called ACE inhibitors are available. Pretty standard medicines have been in cardiovascular care for decades. Once they become stage C, they now have symptoms. We throw the kitchen sink at them. They get everything. They get every drug that's available. We consider if they're applicable to get a defibrillator, if they're eligible, we use a pacemaker to resynchronize the heart, to get both sides of the heart pump together at the same time. And we recommend they be seen by a multidisciplinary team, be seen and evaluated for heart failure therapy. So really, it really changes the dynamic once they have a deal. The therapies, what do people get if we have heart failure? This is really the core, and within the red box are the drugs that have all been shown to save lives, improve your survival, increase the quality of your life, keep you out of the hospital. And there's really 4 things that are on this list, and that's really the good news. I can tell you that starting back 30 years ago, none of these were on everybody's list, and many of these were not yet invented. So that's good news. I want to talk just briefly about the topic of sudden death. So if you look at people who have heart failure, you might say, well, how do they get into trouble? How do they die, actually? There's 2 ways. One is the heart failure keeps getting worse and worse and worse. So they die with progressive heart failure. The other is that they get a regular heartbeat that doesn't stop, and finally their heart is no longer pumping, and they die. Now, some people survive sudden death. So that's why when you go to the airport or anywhere that you might be in a public place, you see these AEDs, automatic external defibrillators. How many of you have been trained on it? Yeah, quite a few. Okay. So the reason for that is that sudden death is epidemic in our population. Lots of people are at risk, and nobody more than the patient who has heart failure. And so much so that starting about 12 years ago, we did a bunch of trials, and we said, gee, can we find out who's at risk for sudden death so we can give them a defibrillator? And the answer was no. You can't predict it. There's certain things that help you understand the propensity, the ejection fraction, the cause of their heart disease. But basically, it's really a crapshoot that you don't know who's going to get it. And so we actually do prophylactic implantation of patients who are at risk of a defibrillator. And that has been shown to decrease the risk of sudden death tremendously. This is what a defibrillator looks like. It's a lead that goes on the right side of the heart, that goes down into the bottom chamber on the right side. And these little boxes that are implanted under the skin can detect an irregular rhythm. They are very smart. They know when the person is exercising or running versus when they actually have an irregular rhythm and deliver a shot. Actually, these boxes are very sophisticated. They do other things. They try to please the person first, but they ultimately deliver a shot and save the person's life. The other is this pacing therapy that takes a heart muscle. When the heart gets weak, instead of both the right and the left side pumping together at the same time, it gets out of sync. And that decreases the amount that the heart pumps with each beat. We can now put a lead on either side of the heart and get the heart to be synchronized again. And this has been shown to improve quality of life, improve exercise capacity, and save lives. And that's just, this is really just to show you that even who gets a CRT device, it's not like one doctor thinks they should and another doctor thinks they shouldn't. This is exceedingly codified and really broken down into very specifics about who should and who should not. Now let me just say, I'll close here because I want to see if there's some questions or a word about transplant. I did heart transplant practically my whole career. It's been really a remarkable and life-saving therapy. There's a couple of things that, like all things in life, when you get a transplant, you're not cured, you're exchanging one set of medicines and problems for another, but the quality of life of patients who get transplanted is remarkably better. The question that always comes up is how long do transplants last? And that's what you're seeing on this slide here is basically the half-life. At the end of 20 years, it's probably only about 20 or 25% of those patients survive. There's lots of things that modify that. And the problem is that on a daily basis is the person who gets a transplant is someone else's tissue inside of them, and your body is trying to reject that tissue. So it's really a struggle between suppressing that rejection versus exposing them to risk of cancer or infection. But this has gotten remarkably better. The survival at 1 year at most places around the country is over 90%, and it's really a life-saving therapy for people who need it. Because in the United States, we probably only transplant about 2,000 to 3,000 people a year because of donor availability. And there are thousands and thousands of people near death with heart failure. We needed to create one further therapy, and that's been a mechanical pump. And that's been really the holy grail of heart failure treatment for many years. And really in the last 7 or 8 years, it's come into full form with these devices called left ventricular assist devices. They're devices that get implanted directly into the heart. They take the blood out of the heart. They have a little pumping mechanism that pushes the blood back out to the rest of the body. And so they really take over, in most cases, do virtually all the work for the heart. They're connected through a wire to outside the body, which is connected to a controller that controls the rate of the pump, and they're connected, at least for now, to a battery pack. But these battery packs keep lasting longer, and the survival of these patients keeps getting better and better and better. And there's a variety of them. This happens to be let me finally get to the end here, so to speak. But this is an interesting drawing that was created several years ago, and this is looking at the functional status of the patient. What typically happens is, if this is the optimal functional status, when the patient finally presents with heart failure, they decline considerably, and they get diagnosed and treated, and they come back to a better functional point than they were here. And there may be a period of time where they seem relatively stable, and then they have another exacerbation. And they go into the hospital and they recover a little bit. And then what happens is they start having exacerbations that are more frequent, more severe, and the recovery is never as full. And this is sort of the window of opportunity to really begin to understand how far along they are and look for advanced therapies for them. And because if we don't, they are going to slowly, progressively die and fail. And so this is really the issue. The time that we see most patients is when they're referred to this advanced stage. And the difficulty is we now have a dilemma, because we have to go in and we have to talk about transplant if they're eligible. We have to talk about a ventricular assist device, or we have to talk about palliative care and then the life care. That's a difficult conversation. It's very hard for patients and families to absorb all of that. So we'd like to find out patients earlier and know about what their functional status is and their prognosis. Can I say one more word about this guidelines? I think it's one last minute. So I wrote guidelines for more than a decade of my life, and I think this is how most people look at guidelines. That, they're not very rigid. They're not really, but guidelines are used by the payers. Guidelines are used by the government. Guidelines are used by everyone these days, and this is really, it's really a fairly sophisticated art, because the guideline actually gives you wordage that tells you what you should do, shouldn't do, may do, things like that. And it's an interesting process. So, like all of our lives, they're fairly regulated, and the guidelines drive a lot of that. I'll just give you one example. This is, let me show you this one. Non-invasive cardiac imaging. So this is patients with new onset heart failure presenting with decompensating heart failure. They did a chest X-ray. They say, well, what's the evidence of that? What is the guideline? So it says, well, it's at level 1. Meaning everybody should do this. Everyone should get a chest X-ray. You say, okay, what's the evidence of that? Well, there was never a trial that said, okay, we're going to get half the people with heart failure X-rays and half that. You just can't do that. So it's level of evidence C, meaning that it's expert opinion. Expert opinion is just a bunch of men and women getting together and saying, we think that's the right thing to do. Then there's other therapies, for example, ACE inhibitors, level of evidence 1, level 1, level of evidence A, meaning that there's multiple trials. So reading guidelines is a little bit tricky. You not only want to know what the words say, but you want to know what the level of evidence is and the supporting data. I think I'm going to stop there, and thank you very much.